So good morning. Like I said, I am Dr. Herme. I'm one of the psychologists on the pain team, and I'm going to be talking with you today with Dr. Rosales. We're going to kind of like tag team it, so we'll go back and forth. But we're really excited to talk to you about some of the mental health treatments we use in pain management. So as an introduction, I thought I would introduce what our division does. So to give you a little bit of context, we offer a lot of services in our clinic. So first of all, we have our pain management clinic, and this is where we treat kids that have chronic pain. We also have our inpatient pain service, and this is where we treat kids in the hospital who are experiencing pain and having a difficult time managing pain. Oftentimes these are our post-surgical kids. And we have our pain rehabilitation program where we treat children who are having a difficult time functioning because of their chronic pain. And we have our dog therapy program, and who doesn't love dogs? But because we have all of these services, we also have a lot of different types of providers on our teams. So we have nurse practitioners, we have psychologists, we have anesthesiologists, psychiatrists, acupuncturists, and a physician's assistant, and again, that dog therapy program. So that's a little bit about us, and of course, today we're going to talk to you about pain. So we want you to learn a little bit about the differences between acute and chronic pain, as well as be able to identify coping strategies for managing post-operative pain, as well as chronic pain. And then we want to teach you a little bit about our different behavioral medicine techniques based on child age and development. So pain. One of our common definitions of pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage, or described in terms of such. So essentially what we're saying is that pain is an unpleasant sensation, and it can be because of tissue damage, but it can also be once tissue damage has healed and there's no longer any tissue damage. We can still feel pain when there's no damage. So we're going to talk a little bit about that in our acute versus chronic pain. So acute pain is usually short-term in nature, and it usually results from surgeries or procedures. It tends to resolve once that tissue has healed, and it's often associated with physical signs of stress, including things like feeling tired or fatigued or feeling like you have an increased heart rate. And acute pain can have negative lasting effects like learned fear or anxiety. It can lead to chronic pain, and it can lead to avoiding some medical care. But we're going to talk about interventions to target those things. So chronic pain then is described as pain that persists beyond 3 months or beyond when you would expect a child or teenager to heal. And it can exist even after that tissue damage has healed. So where acute pain tends to come from damage to the tissue, chronic pain usually persists even though there is no more tissue damage. And this also can be associated with physical signs of stress, that fatigue, that soreness, feeling down. We also know that sometimes kids who are in chronic pain will look like they don't have any pain. And so it can be difficult to differentiate between when a child is having pain and when they're not having pain. We also know that chronic pain is really common. 25 to 40% of children and adolescents report some part of chronic pain. So we want to continue to target these things, right? Because we want to treat the pain. And so we treat pain from the biopsychosocial model of pain here. And what that means is pain is super complicated, and because it's super complicated, we want to treat it from a variety of angles. So we know that pain tends to be biological initially, right? That damage to tissue. But depending on what's going on in our lives, like social situations and psychological situations, it'll change how we feel about pain. One of the examples we really like to use in clinic is imagining you're opening an envelope. And as you're opening this envelope, you get a paper cut. But inside is a winning lottery ticket. Are you going to be thinking about that paper cut, or are you going to be thinking about all the things you're going to buy? You're probably going to be thinking about the things you're going to buy. Now instead, let's imagine we open that envelope, and inside are bills or a failing report card. This is going to feel way more stressful. And because we're feeling that stress, that pain and that paper cut is actually going to feel a lot bigger. So when we treat pain, we can't just treat this medical piece. We also have to treat the social and the psychological piece, which is really what we want to talk to you about today. And I'm going to hand it over to Dr. Rosales, who's going to talk a little bit about pain by developmental stages.
Thank you, and good morning, everyone. I feel really thankful being here with you today. And so, yes, we thought that talking about pain and pain management throughout the lifespan for youth would be really important, especially for this conference, right? Given the number of surgeries or painful procedures that babies, children, and adolescents may need to go through. Oops. Okay. And so the field of pain management has come a long way in the past few decades. You may know this, but something we're not proud of is that a few decades ago, we actually thought that pain in babies really didn't exist, or that babies experience much less pain compared to adults or children. And there are various reasons for that, but one of them we could think of is their ability to express themselves, right? So babies can't necessarily tell us where they're having pain, when they're having pain, and things like that. But we now know that babies do experience pain. And so I wanted to start with a slide that kind of focuses on noticing pain behaviors in babies. We could argue that that's one of our most vulnerable populations, right, because of their communication. And so the theme of what you're seeing up here really is abnormal behavior. And so when we're thinking of crying, yes, all babies cry. I don't want you to go home and feel nervous that your baby's crying. But it's abnormal behavior. Is my baby crying more than usual? Is it higher pitched? Is it taking a long time for my baby to soothe? A lot more than it used to take him or her. Also noticing, face changes. Obviously when a baby's crying, and I'm not going to replicate the face for you, but you can imagine a baby crying and wrinkling its face. But it's the more distress that's shown on the face. The body tends to look a little bit more stiff. They might stretch out their arms and legs. Their temperament may seem more fussy, difficult to calm. Eating is a big one. So if you notice that your baby's eating much less or not at all, that is a big sign. And sleep is also a big one. If they can't get comfortable throughout the night, that is typically a sign that we need to pay attention to pain. Okay, so how can we help? Caregivers, parents can help babies soothe, and we're talking about acute pain here. So you're going to notice that we're going to talk a lot about 5 senses in babies, children, and adolescents, actually, and it's just going to look a little differently. But for babies, most of us have heard things like skin to skin is good, to regulate their bodies and things like that. Well, it's also true for pain. So holding a baby, having skin-to-skin contact when they're either, one, going through a painful procedure, or they've recently been through a painful procedure is really helpful. So for example, let's say you're at a doctor's office and your baby's about to get either a blood draw or an immunization, something that's painful. You can ask the providers if it's okay to hold your baby. Psychologically for babies and for anyone really, laying on your back, for example, and having your arms or your legs held down is a highly, highly stressful position. We don't recommend it unless, you absolutely have to do that. So holding them, even having immunizations while you're holding them, even while you're breastfeeding, things like that for mothers who are breastfeeding. Visual and auditory distraction, having their favorite toy. This is also a time where I tell parents, be flexible. So, I'm not going to advocate for phone usage, but if this is the time to take out Barney on your phone and show them Barney just to get through a procedure. Also, babies soothe orally, and so having their pacifier, dipping it in sugar water as opposed to honey. Sugar water can also provide that neurobiological benefit. And for breastfeeding mothers, I call it the power combo. There's holding, there's skin to skin, sucking, and sweet taste. It's all in one, so it's amazing what their bodies can do. Oop, keep doing that, sorry. Okay, So we're going to gravitate towards children and adolescents. So we're going up in our age spectrum. Now, in theory, communicating pain is much, much easier in childhood and for children and adolescents. However, it's not perfect. And so in our pain clinic, we use things like 0 to 10 scales, and you've probably heard of these before. So on a scale from 0 to 10, how much pain are you having today? And for kids, we might modify that, right? So 0 being like as if a kitty was touching your hand, and then 10 if a dinosaur touched your hand. So we try to get a little bit creative, but it can be also challenging for youth to tell us when they're having pain, where they're having pain, describing the pain. Is it sharp? Is it dull? Is it achy? Things like that. So then what can we do? How do we support our youth? So again, like Dr. Herme said, we may see them in clinic, we may see them in the hospital after they have surgery, we may see them in the rehab program. One thing that psychologists do in pain management is we focus on adherence. So there can be amazing medications out there for pain and for youth, but they only work as well as we give them to our kids, right? And so many studies out there have shown that for various surgeries, and this is a study I'm going to go over today, but kids do not get the recommended doses of medications. Now, that may or may not be surprising. So in this case, this is a study for tonsillectomies and adenoidectomies, and on the first day after surgery, which is a pretty painful day, most youth did not get the recommended doses of medication to manage their pain. Now, this is not a slide meant to shame these parents, but a slide to really kind of validate that for most parents, for most caregivers, for most of us, including myself, we don't want to give our kids medication necessarily, right? We can agree on that. The challenge that I want to bring up to this group is, like Dr. Herme said earlier on, acute pain, so pain after surgeries and procedures, can, if not managed enough, lead to chronic pain. It could also lead to behaviors and changes, biological changes in the brain and the nervous system that could complicate things in the future for youth who need to continue getting care. And this is why we're talking about it, to inform you about that. So we looked at the reasons. So why aren't parents giving these medications? We know they love their children, they want to do the best by their children. And so most of the reasons why were actually fears, right? We would know that. Fears of dependence were cited, right? Fears of damaging organs were cited, and things like that. And they're valid. We hear about the opioid crisis. We hear about all sorts of things in the media that are really scary, and a lot of that information has validity to it. However, my message to you is to encourage you. Have an open conversation with your providers instead of kind of, okay, nodding, thank you for, that medication, all right, I'm going to go on my way. But share with them. I really like when families, we try to use a collaborative effort. And I really like when patients and their families say, we don't really love giving a lot of medication. These are our values. These are our concerns. And that way, we can have an open dialogue, right? This is a group effort, a dialogue about, okay, what are your concerns? Let's try to understand them. And providers may modify their approaches based on your concerns, or they might equip you with information and make sure that you're not misinformed, right? And so that's one thing that I want to really drive home today, having those open dialogues with providers. Okay. So in terms of behavioral medicine, so there's pharmacological medicine, right, that we just talked about the study, behavioral medicine techniques. I'm going to go over some of them. And, too many of them. I'm going to go over some of these in more detail, but what I do want to say is I want to go over why we do these type of relaxation skills. So when youth have pain, depending on their age, and they need to, let's say, come to doctor visits. Well, let me do this. Show of hands. How many of your kids have expressed that they do not like going to the doctor, they do not want to go to a hospital, things like that? Okay. All right. So this is getting to that. having to come to the doctor's office or the hospital, getting procedures done, surgeries, etc., can feel like a loss of control. I have to do all these things, I don't want to do them. And more youth might feel disconnected with their bodies. They don't have a choice, they have to do these things, these things can really hurt, they don't want to go to doctors, etc. So we want to show them ways to get to know their bodies, to see and to notice cues in their bodies when they're feeling stressed or worried, because that can make the pain worse. But then ways to do something about it, find ways to relax their bodies. And that's what we mean by that mind-body connection. So one of them, illustrated by this cutie, is progressive muscle relaxation. And that, excuse me, involves progressively tensing muscle groups and relaxing them. And with that, again, the goal is body awareness, noticing when my muscles are tight, noticing when they relax, how I have control over my body and I could do something to help it. Guided imagery and meditation. You may have heard, raise your hand if you've heard these terms before, like either you know of an app or you've done it with a provider or things like that. Great. So this is not something that seems totally new, but the way we use it is, again, we're giving youth a way to try to manage their pain, to have the power. You know, some of the guided imagery exercises, for example, talk about reducing your pain, noticing and it uses imagination, right? To imagine either places that are really relaxing, like this picture, or to imagine your body, and to imagine your body healing, to imagine your body reducing pain and things like that. And that has been shown to actually provide some comfort and decrease pain for youth. So I know I'm kind of going over this. If I had more time, I would want to show you all how this actually works. But we will get to some exercises. So grounding, remember when I said 5 senses is kind of the theme? With babies, it was things like skin to skin and touch and distraction, things like that. For youth, it's similar, but one thing we wanted to talk about is a strategy we use that's called grounding. And this also uses our 5 senses in a way to focus on the here and the now. And that way, usually our brains get fewer pain signals, okay? And again, it's about that sense of control. So we thought what we'd do to break it up, and we wanted to try to be as less lecture-y as possible. We wanted to do a little activity with you, okay? So for this activity, I need you to identify an object. So either in your purse, it's already in your hand. If you're eating something, drinking something, that one's perfect. If you have something in your pocket that you want to pull out, just some object. And I'm going to do a little exercise that we do with our youth. Now, for youth, let's say in the hospital, a big one is a lovey, you know, their favorite stuffed animal. This is a good exercise to do that with a stuffed animal. But you guys might have your favorite object, which may be your coffee, and that's totally fine. Okay, does everybody have something to work with? All right. Okay. You don't need to tell me, but just to yourself, describe what it feels like. Get really curious, like you've never seen that coffee cup ever, like you've never seen those keys ever. You know, I tell my patients, get really close to it, see the minute details, see the little scratches you've never noticed before. What does it feel like? What's the temperature? What does it look like? What do you notice? The closer you get to something, you may notice different patterns and different shapes and colors. You may rotate it and notice different things. What does it sound like? If you jiggle it, if you shake it? Good job. I hear them. What does it smell like? You may or may not want to do this. It's up to you. Again, you're in control. What does it taste like? Again, be cautious with this one. But it's about evoking and engaging our senses as much as possible in order to break up some of those pain signals, but then also everything that goes along with pain. Worries about pain, distressed feelings about pain, things like that. Okay, so I'm going to pause here and hand it back to Dr. Herme to talk about chronic interventions.
So, treating chronic pain. Dog therapy, we love. So, earlier we mentioned that biopsychosocial model, right? And how pain is super complicated. We also have what we call the biopsychosocial spiral. And in the spiral, we have stress, right? We know that pain and stress are kind of frenemies. If you have pain, it's a stressful experience, and stress can increase our pain. And so we have this cycle where, we might feel pain, and then we have a worry thought, and then we have a sad thought related to the worry thought, related to the pain, and then maybe we worry that we're not functioning like other kids our age. And you can see how we can sort of start to go down what I would like to call an anxiety tornado, where we go through what ifs, and we feel really sort of hopeless and sad, and that can cause stress for the family system. So in order to treat pain, we have to start to break this cycle. So we're going to break it up in different places and start treating in different areas. So because we're going to treat it from all different areas, I'm going to go over a few types of treatment we do. The first one is called biofeedback. And biofeedback is a type of service where we're really promoting that mind-body connection. In our kids with chronic pain, oftentimes they'll try to distance themselves from their body, and they don't want to pay attention to what's going on in their body because that hurts, and those internal signals are kind of all off. So biofeedback is this type of therapy where you get hooked up to a computer. As you can see, our young lady here is wearing a breathing strap, and what she's actually learning to do is take deep breaths in a calming and rhythmic manner that's going to relax her body and also have her feel more control over her body. This is only one way we do biofeedback. There's different other ways we get feedback from our body, such as temperature in our hands, different muscle contractions, what our skin feels like, and our heart rate. But it's a really nice therapy that promotes that mind-body connection and, again, shows us control over our body, which helps kids feel like they have more control over their pain. Another type of therapy we like is cognitive behavioral therapy, and this tends to be one of our gold standards, and that's because it really works on breaking up the different components of that biopsychosocial model. So we have our thoughts, and they're connected to our behaviors and our emotions and our body sensations. And knowing how all of these things are connected can help us treat and change things. So cognitive behavioral therapy works on the principle that we have emotions. And our emotions are information that we're gathering from the world around us. So we feel worried for a reason, we feel sad for a reason, we feel happy for a reason. All of these emotions are meant to give us information. However, our brain really likes patterns. And so when we get, for instance, scared of something, the more we avoid it, the more scared we get, the stronger that pattern becomes, and the more likely we are to have sort of negative thoughts and negative behaviors. So CBT really works to sort of target these. So the goals of CBT are really to change our thinking about pain. So one of the things is kids and teens don't realize how much they're thinking about pain, or how much they're worried about it, or how much stress they're having because of their pain. So we really like to explore our awareness around pain beliefs and thoughts and behaviors, because the more awareness our teenagers and our children have, the easier it is for them to make changes. And we want to break that downward spiral by altering our thoughts and our behaviors. And we want to reinforce those desired behaviors. So I thought we could give you some examples on how we would work with teens and adolescents to break this cycle. So in our first example, we're going to take a post-surgery kid. And the thought might be that the pain is going to last forever. And the behavior is that they might avoid moving. They might avoid engaging in the activities they've actually been cleared to do because they're scared of the pain. And that emotion would be that scaredness, the worry, the anxiety. And that's actually going to probably increase the awareness of the pain. And in increasing that awareness on the pain might increase the pain itself. So we have to learn how to break this cycle using our thoughts and behaviors to change these things. So we're gonna first start by changing the thought. So instead of I'm gonna have pain forever, we're gonna alter the thought to I have pain and my team is trying to help me manage pain. So this is what I like to call a validating statement. We're not taking away the experience of having pain, but we're also adding something to it, right? And my team is trying to help me manage. So it gives a sense of control over I have this and there's something I can do about it. And the behavior might then be engaging in recommendations. So they might then engage in the physical therapy they're supposed to, or the movement that's been recommended to them. And in that, they might still feel worry, because this is post-surgery. Kids are allowed to worry. But they also then might feel more trustful of their team. They might feel more confident in themselves and their ability to help manage their own pain. And that's going to lessen that focus on pain and really promote that they have control over their body. So that's one way we can change the cycle. In the next example, we're going to do the other half of that diamond. We're going to change the behavior. So instead of avoiding moving, we're going to use a coping skill of deep breathing. And we're going to focus on changing the cycle using this deep breathing. So it's a little bit different, right? We're not talking about the thought. We're not talking about the avoiding moving. We're just going to do deep breathing when we're having pain. And then the thought might be that my body is relaxing. I can feel it calming down. And the emotions might be relaxation, feeling calm, and really realizing like that I have more control over the situation. And that's going to lessen the focus on pain. Again, it changes the way the cycle goes, but both are very powerful motivators and actions for change. So in our next example, another common one we have with kids that have chronic pain is I don't want to go play with my friends, or I don't want to go out with my friends for teenagers because the pain is going to stop me. So a thought might be, if I move a certain way, it might increase pain. So I'm going to sit out, I'm going to cancel my plans. And I'm going to feel worried and stressed and maybe lonely because I don't get to like hang out with my friends the way other kids do. That's going to probably increase my pain and heighten my awareness of my pain and make me feel a little bit different, right? Because I can't go do the things other kids my age can do. So again, we're going to break that cycle. And instead of saying, I can't go because I have pain, we change the thought to this may increase my pain and I've been cleared to engage in this activity. Again, using those and statements or giving an alternate thought that's going to be powerful and sort of change the direction of the cycle. So here the behavior then becomes, I'm going to engage and stick to the plans. And maybe your teenager, your child then feels confident and they have achievement, they feel connected to their peers, and they might feel happy, right? If they're out playing games with their friends or hanging out. And again, being with our peers, hanging out with friends, doing activities is going to lessen that focus on pain. So we're going to change the behavior. So we're going to engage in plans and activity. And we might think, my body's keeping up with me. So in this example, just by going out, we can see that the body is stronger than maybe our pain beliefs have led us to believe. And we can keep up with our friends. We're going to feel maybe happy, connected, hopeful. And again, because we're out with our peers and having fun, we're going to lessen the focus on pain. So that's kind of my brief introduction to cognitive behavioral therapy. Another type of therapy we tend to use is called acceptance and commitment therapy. And this type of therapy really changes the focus on controlling pain. We have pain in our lives, and it's going to be higher at some points, it's going to be lower at some points. What this type of psychotherapy focuses on is functioning, increasing our goals based on what we value in life. So what are our values? What do we want to get out of life? And by accepting the amount of pain we have, how can we achieve those values? And what it does is it really promotes psychological flexibility and, again, changing our thoughts, but in a more sort of acceptance way. I'm going to hand it back over to Dr. Rosales now, who's going to talk a little bit about sleep and chronic pain.
Okay, show of hands. Who likes to sleep here? Okay, awesome. Okay, just checking if you're awake. And also show of hands, who has noticed that their children or a kiddo they know has struggled with sleep and pain at the same time? Okay. All right. So I'm here to talk a little bit about sleep and chronic pain and how to help with it. So we know that there's a huge overlap or correlation between pain and sleep. And it kind of makes sense. If you have chronic pain, which means like pain for at least 3 months, your sleep is likely to be disrupted. But it also works a different way. So experimental studies, those studies that happen in labs, right, tell us that if you keep waking up a person at various times of the night, they will develop hyperalgesia or a high sensitivity to pain. They may also develop pain, period. So that's really interesting, right? So we're talking about healthy people, they go to this lab, they wake up throughout the night, and their body changes. It's more susceptible to pain. But what happens to our kiddos who have chronic pain or who need to go through painful procedures? How does their sleep get disrupted? Sometimes the way we cope is helpful temporarily, and sometimes it turns out to be a little bit maladaptive or not that helpful. So we may exercise or move much less. We may use our phones more, spend more time in bed during the daytime. We might have a hard time setting limits with our kids because, you know, they're not feeling so great, right? Separation anxiety can happen. If our kiddos are having pain at night, they often want caregivers by their side. And then there's a lot of daytime napping. And all of these things can really affect sleep at night, which then trickles into everything else. Waking up in the morning, that's a tough one. Going to school in the morning, being social, things like that, which can ultimately affect mood, and mood, as we heard from Dr. Herme, can also affect pain. So what do we do about it? I'm just going to give a really brief overview of what we can do, what you can do at home, but then also in cases where sleep is highly disrupted, what we would recommend, we would recommend in terms of treatments. Okay, so sleep hygiene. Sleep hygiene, hopefully you've heard that term already, but it basically is a set of recommendations that have been researched to show that if you do these things, it'll help your kid, it'll help yourself sleep better. Things like keeping them on a schedule in terms of bedtime, keeping things consistent, not napping during the day if they're struggling to sleep, not using blue light emitting devices like our phones because it kind of tricks our brains that it's daytime. Exercising or moving regularly to feel tired enough to go to sleep, that type of good thing. It sounds really easy, and I will say as a psychologist and also a mother, it's not easy. What it looks like in real life to get your kid in bed is not as easy as saying, let's have good sleep hygiene. But it is really important. We also use sleep diaries when we're having a hard time identifying why our kids are having a hard time sleeping, and that's just to give more detail. Exercise is a big one. So Dr. Herme, myself, and also Rubi, he's going to talk in a second, we all work as part of the rehab program, and we see a huge difference in sleep once kids are moving more. So that's my plug for exercise. We use relaxation techniques because sometimes it's more about worries that keep us up. And with kids, it's not like they're going to say, you know, Mom and Dad, I was feeling really worried, so I'm having a hard time sleeping. It's more they're restless. They are keyed up, things like that. And so finding ways to relax their bodies, helping them relax their bodies is really important. Now, sometimes sleep becomes clinically significant in terms of disruption. So what is an example? A common example is delayed onset of sleep. So that means your kids are sleeping at least 2 hours or more after their bedtime. And so with that, we tend to use other techniques like bedtime fading, which is basically a technique that gradually changes the bedtime, and CBT, but for insomnia. So it's similar to what Dr. Herme talked about, but tailored toward that sleep disorder. And family therapy to basically support the family system in getting our kids and to better sleep habits. Okay? All right. So that concludes our portion of the presentation. Thank you all for listening.
Okay, so I am Dr. Rubi Buxton. I'm a physical therapist and on our rehab unit. And I also am one of the physical therapists who are part of the pelvic floor dysfunction clinic. We work closely with urology and psychology. To start off, this is such a PT thing to do, but will everyone just stand up? Great, thank you. I'm not going to make you guys do anything crazy, but maybe let's just reach up and take a deep breath. Let it out and reach out to the side. Maybe let's do that one more time because it actually felt really good. In and out. Maybe give yourself a hug. Kind of wiggle your body. Shake out your hands. Take a few marches. Okay, take a breath and sit. Great. Welcome to PT. I'm just kidding. So I'm going to go over a really brief overview of just why would physical therapy be involved, and then kind of go discuss just very briefly in regards to like how we would help with the pain aspect of when someone's having pain. Okay. I will be out in the area right here in the wellness fair, and I'll have a table there. So afterwards, if you have specific questions or there's like specific things you want to know, happy to discuss further. But just so you know, this is going to be very brief. So don't feel like, oh, this is it, just so you know. Okay, so why physical therapy is involved in anything to do with the pelvic floor or urology. So who has had physical therapy before? Okay, so a lot of people in the room. So we still will work with muscles. We still talk about exercise, but it's just in a little bit different perspective, right? We use it a little bit differently. And when you think about this area, thinking about children is very different than what you're going to think about in regards to pelvic floor, which means our pelvis is here. And it's the area, the muscles, everything that works around that area. If you can imagine as an adult how challenging it is to really think about that area, most of us don't even talk about it. And sometimes we do struggle with different ideas about what to do to strengthen it or to help it work. Now think about a young child. That's so confusing. I mean, who thinks potty training is confusing? It's like, when do we start? What do we use? What do we do? Different ideas. So this is a very, very challenging area that sometimes we just need a little bit of help or education to figure out what's the best way to approach it with a child, right? This is a really, really difficult subject. When we think about pelvic floor physical therapy, we're really talking about those muscle groups, like I said, that are around the pelvis, okay? Definitely the reproductive area, the private parts, right? And so we're really focusing on that area. What these muscles help to do, they help support the pelvic organs, right? That makes sense. They help us or assist us with bladder control, so when you have to urinate, when you have to go pee-pee. And they help us with bowel movements. So if you have to poop. That's a really hard thing to do if those muscles are not working properly, or they're working a little bit different, or we don't really know about them and we're just not really thinking about them. So that's where physical therapy gets involved, those muscle groups. So why would you see a PT for your pelvic floor, for these muscles? Well, there's a few different reasons, and this isn't limited to just this, but if you're just speaking about pelvic floor therapy, it would be because you have some type of incontinence or your child has some type of incontinence. So maybe you notice, you know what, their underwear is kind of wet, especially when they go running or jumping. Or maybe, you know, after they go pee-pee, and then you put their underwear on, and you help them wipe, or they learned how to wipe, but it's still like at the end of the day, it's stained, there's like urine stains, or there could be like poop stains or streaks, and you know that they're cleaning themselves. They could have what some people call accidents, where they really want to use the restroom, and they just can't hold it, or they tell you, I just can't get there. And so those types of things, sometimes we can help with that. And it may not just be because they're not trained or they don't know how to. They might just need a little bit of guidance. And we might be able to retrain those muscles. One of the big things we asked about is how this works. And I'll talk a little bit more about that as we discuss in these slides. One of the other reasons you might have issues with pelvic floor might be if you have difficulty urinating, it hurts, or it just won't release. You sit on the toilet and you have to sit there a really long time for the pee to come out. Or when you sit on the toilet and it hurts, or you can't really get it to relax, those muscles to just let go if you have to poop. Same idea. It's just learning that about your body. Difficulty with constipation, constantly constipated. They're not going daily. You should be having a bowel movement. You should be pooping daily. If the child is not pooping daily, you may have already seen the urologist or the gastroenterologist to figure out, like, why are we constipated? But sometimes we can help with that. And that's what physical therapy collaborates with the teams with. And then if there's chronic pelvic pain, we heard about pain. This is specifically for the pelvic area, and sometimes we can help with that, and we'll talk a little bit more about that as we move on. So what does pelvic floor PT do? There's a few different things that we focus on. One of the first questions we get, and I think one of the worries that happens is usually when you go in and you see somebody because you're having problems using the restroom for whatever reason, is, especially with children, it's such a private area. It's an area of anxiety. And so the first thing we tell the parent and the child when they come to see us is clothes are going to stay on, especially on the evaluation. And that usually we hear like, because it's scary. So we start with clothes on. And anything that we're going to do is going to be over the clothes, and then parents are involved. So we often will show parents how to do it on themselves and then the child. So everything's kind of open and together. And then that's how we start with our evaluation. It's a lot of figuring out what exactly is happening so that we can provide the proper education, the proper pelvic floor exercises. For adults, you may have heard something like Kegels. Who knows what Kegels are? Well, we kind of know what they are. Who knows really what's happening? But for a child, that's a really challenging thing to try to get them to understand. That part of their body hasn't really been as explored quite yet. And so we need to figure out other ways that we can get those muscles to work without just using something like Kegels. Not only that, but sometimes we don't need strengthening, we need relaxation. And so depending on what it is and figuring out the right education and the right exercises, we can help them actually be more effective in learning how to control their body. We do manual therapy, and what that is, it could be muscle releases, it could be abdominal massage, scar massage, and that really goes a long way. And we teach families how to do that, because doing it one time in the clinic is not going to get it done. But helping you to learn how to do it, where it's needed and how it's appropriate for your child is really helpful and useful, not only for the child, but also for yourself. And we also help with pelvic floor biofeedback. So we talked about biofeedback for pain. We also use it for specifically pelvic floor therapy. And then also electrical stimulation, which I'll go over very briefly when it's necessary. So I'll kind of move this way so you can kind of see the education we use is very child specific. So like I said, it's not squeeze, let's do some Kegels. It's very specific for the child. It's using child-friendly language that they understand and using activities and information that will help them process the information. Sometimes they need to learn a little bit more about their body and their area so they can really understand what we're trying to say. And so we help the parents we collaborate with parents to figure out how we're going to say what we need to say and what body parts we're trying to get them to move. Also learning specific hygiene habits, toileting habits, the things that maybe they're doing and maybe that's contributing to what's happening. So really getting into those details. Pelvic floor exercises, figuring out what exercises we're going to do. They're going to still target the muscles that we need either strengthened or relaxed, and providing those specifically for the child for the right age. We're obviously not going to be able to have a child who's 2 or 3 perform the same level of exercise that a child who's 10 or 12 will do, or that a child who's 14 or 16 would do, an adolescent. So it's really knowing age-specific exercises, movements that will help strengthen those muscles in the pelvic area or relax them without having to do, exercises that an adult would do. So what would those be? Things like, what does squatting do? What does climbing do? What does balancing do? What does strengthening the lower part of your leg, like your calf muscle, have to do with strengthening your pelvic floor muscle? It's incredible what you can do without actually having to target specifically the pelvic muscle area directly. So indirectly figuring out those movements. That's where coming to see a physical therapist may be helpful, to help guide you in what your child may need. And I talked about the manual therapy. Sometimes it's like really figuring out posture. Is there any type of asymmetry? So is one side of the body a little bit different than the other side of the body? Would that be affecting it? It could sometimes. Sometimes it's negligible, but sometimes it can affect it. So knowing that about your child is really helpful, and we can help provide some suggestions or provide some specific muscle releases that'll help with that asymmetry. Blood circulation to the area, like with the massage, and different types of mobility to the massage or to the body, to the joints. The pelvic floor biofeedback, we've been able to have some really nice collaboration with our urology department, and being able to pair up the physical therapy movements with the biofeedback so that the child then learns and sees how the exercises are specifically targeting their pelvic floor muscles. So they can, just like they can see when they take a deep breath and release it, they can see that on the screen with pain. They do that with the pelvic floor muscles. So let's say we have them do a specific movement. We have them what we call do internal, external rotation of the hip. So that means the leg's going out, the leg's going in. So if you do that movement, what happens to your muscle? Or maybe while doing that, the muscle isn't really being targeted appropriately. So we can see that and then in the moment give feedback to them that way. And so that's how we can collaborate with that if it's appropriate. It's not all of these are not always necessary, and that's why it's important to come in to see physical therapy or to work with the team. Electrical stimulation is sometimes used. Has anyone gone to physical therapy and they put on these little electrodes, or sometimes you go to a chiropractor and they put on these little like patches, gel patches, and they hook it up to a machine and it kind of tickles you like ants on you, and then sometimes it actually makes your muscle kind of tighten up. Yeah, we don't make muscles tighten up. But what we do is we use it as a feedback. So we help the child by placing it in areas like the lower back, the abdomen, and the lower inside of the leg. Those are the same nerves. And so sometimes by doing that, there's a lot of research that talks about how just providing that feedback and using it with the specific exercises that your child needs can retrain the body and provide some mindfulness, some education about their body. And we're able to help them see what they need to contract, squeeze, or relax. So if it's appropriate, we use that. So the specific treatment plan. there is no cookie cutter. Every child is going to be different, right? And how they respond is going to be different. And what they need may be different. So if an individual really, but we're really speaking specifically to the child, if a child needs help with some type of issue with their pelvic floor, we can't just give a handout and say, do these Kegels, sit on the toilet. It doesn't work that way, right? We know it's much more complicated. The coordination that's involved to be able to focus on that muscle group is so extensive. It's incredible. And so we really want to come up with a treatment plan that's specific for the child. I will have some really quick things that you can start to do for your child to see if they're able to do it. And then just to get you in a mode of trying to figure out what can we start with, and then get you into a consult with physical therapy or speaking to your urologist or one of your medical teams to discuss if it's appropriate for you. Now, if pain is an issue, we usually look at the connective tissue. So the connective tissue is what's between the skin and the muscle. So there's skin, there's muscle, and then there's this connective tissue in the middle. Sometimes that connective tissue can become like hard and dense and stiff. And so that'll happen a lot of times if the body isn't working just specifically, or if you've had like a surgery. So we need to really address that to make sure you're moving to the best of your ability, and that will kind of help with some of the actual organic pain, which means there's something going on physically that we need to help with. So we know that if the connective tissue is dense or stiff and it's not moving like it needs to, it can contribute to actual pain. And this can cause dysfunctions with muscles, joints, nerves. If any of those items are not working properly, they can contribute to the tightness or vice versa. So they're connected. So then that's what we do, is we help mobilize it or manipulate it. And it just means we're going to be working with that connective tissue, and then we teach you how to do it for yourself or your child. One of the big things is if you've had surgery, every time you have surgery, you see that scar tissue develops. Sometimes the scar tissue is more intense than other times, and definitely different people will develop scar tissue differently. Every time you cut in, you're going to have some scar tissue. We need the scarring because we need it to close. We need it to heal. So that's like a completely normal thing. What we don't want is that connective tissue that's now dense and stiff to get stuck. So sometimes what happens with scars is they kind of grow down. And I don't know if you've ever seen a scar, if you have a scar, but if you've ever noticed, the scar is either going to be moving, so if you move the skin, it moves around. And that's how the scar should be. Sometimes if you try to move the skin, it doesn't really move. The scar is kind of stuck or adhered. We don't want that. That's like, if you think of a tree, it grows roots. And we don't want the roots. We want it to stay mobile because it allows our body to move the way it needs to move. So a lot of times we can help with that. Or we can help guide you towards back to your medical team saying, we need to work with this scar because it's stopping your mobility. It could be mobility in the sense of constipation, or it could be mobility in the sense of connecting your body or asymmetries to being able to use the restroom. And then this can also cause hypersensitivities. If there's a scar, it's something that's really scary to touch. After surgery, many times you don't touch it for a while until it heals. Once it's healed, it's crucial that we start touching it. The minute you stop touching it, it becomes hypersensitive. The longer you don't touch it, we kind of heard from our psychologist, now it becomes more intense and more intense. And this can be a true pain because of the hypersensitivity of the nerve, which is completely possible, and it can also be this avoidance that we heard. and this now contributes to more pain. So you have this organic part of the nerves becoming hypersensitive, and then you have this other part, the psychological part, right? And so learning how to touch and feeling safe on how to touch and releasing some of that scar tissue is so beneficial to helping control the pain and allowing more mobility. And that's what we want to do, and that's what we help you do with physical therapy, and that's specific to those surgical sites. If it's in a specific area where your child feels uncomfortable with anyone touching, that's when we teach you how to do it in a different area of your body, and then you would learn to do it with your child. So we don't necessarily need to do it to the area, but we teach you how to do it to the area. And at that time, we may need to see the scar so that we know how extensive it is, but we don't necessarily need to perform the therapy without the clothes. And that's specifically for children or adolescents, anyone under the age of 16. Over the age of 16, if you go to an adult pelvic floor therapy clinic, many times there is different types of therapies where you would have to remove the bottom of your clothes. Okay? So just kind of how we talked about with surgery, it's kind of going over the same thing. It's really important that we touch those scars. We learn how to massage them and mobilize them because they very, very commonly contribute to pain and pelvic floor dysfunction, incontinence, or constipation. We want to bring the brain's focus back to the pelvic floor muscles, and we want to re-educate the brain and the body connection. So that's what we do a lot of. It's the neuromuscular re-education, and that's the fancy way of saying we're helping the brain know what part of the body we need to move and how to move it to be most effective. So your team, we want to make sure that your primary care physician is involved, if at all possible. So if there's a pediatrician, usually you see them most often, and so we want to make sure that they're in the loop. Definitely the urology or the GI team, depending on which team you're seeing. We try to keep in contact or communicate with like if the urology refers to us, we want to make sure that they know what's going on and they're able to see a lot of our notes just in case to keep on top of that. We definitely rely heavily on collaboration with mental health. This is a really scary area. It's scary for adults. But if you have problems going to the bathroom, if you have problems with pain in that private area of your body, that's a really hard thing to go through for anyone, but definitely for our children. And so we really, really hope we talk to the parents about really collaborating and allowing us to collaborate and bring in one of the psychologists. Wonderful, the urology department has this great team, and now we have our psychologists that can join us if necessary, or we may reach out to your primary physician and say, you know, we really think it would be helpful if they see the psychologist, the social worker, psychotherapist, in order to be able to process this information that we're providing. It's a lot of information, and it's definitely scary, and can be anxiety-provoking. And then, of course, physical therapy. If you have any questions, I did provide emails, and it's myself, Ruby Buxton, or Hero Aknani, and she's also a physical therapist in our pelvic floor clinic. Yes?
I have a couple questions.
Sure.
I'm an OT,
Oh, great.
and I'm a mom of a child with plastic bladder exstrophy.
Got it.
Everybody in this room either has or has a child with some form of exstrophy.
Right.
And a major feature of that anomaly is not just that it's of the urinary tract, but of the bony structure of the pelvis itself.
Yes.
Many, if not most, kids don't have a closed pelvis. They have a diastasis with an open C-shaped pelvis.
Right.
So, of course, that's going to affect the attachments of the muscles and the ligaments.
Right.
So do you have any research or protocols that you use for children with that particular bony anomaly, or is that something where everybody is still in the learning process at this point?
Definitely some research done. There's a lot of learning happening because I think getting therapies involved, occupational therapy is definitely a partner that we like to help.
Mm-hmm.
Or
I
we
have
like
a lot
to
of
collaborate
colleagues
with.
who actually do pelvic floor therapy as OTs as well.
Right. So
Yeah.
at Children's Hospital Los Angeles, our pelvic floor therapy is specifically with Hero and myself.
Okay.
And we're the ones that do the pelvic floor therapy.
So you and Harold are the ones who are actually seeing your exstrophy patients?
Yes.
Okay.
And so, yes, and that's a part of, because there are anatomical changes, that's part of the teaching and the education we can provide the child and the family to explain why certain things are happening certain ways, to help with some of the scarring, the hypersensitivities, to help figure out, is there a way that we can brainstorm that will help that specific child for whatever issue they are specifically dealing with. Not all of these children deal with exactly the same issues. Some of them may have pain. Some of them may just have specific restrictions to their mobilization of their skin. Some of them may just need a little education on how we can help with positioning in the bathroom. Some of them need help with figuring out how we're going to collaborate with school. So there's a few different aspects that we can approach and help with depending on what specifically that child or that family is dealing with. Yeah. Thank you.
Oh, no, I just wanted to
oh,
quickly
sure.
add. I just wanted to quickly add, you can still continue answering questions because I'm sure there's still a lot, but everyone's anatomy is so different and everyone's ability is so different. And so it's so individualized. I think this is more of an overview. She deals with a lot of our pelvic floor dysfunction patients as well. And so this isn't necessarily supposed to address like everyone in general. I think it's more of a general education on what pelvic floor can offer. And again, I think it is so individualized depending on goals and age, and also just learning the anatomy for the parents and for the child. Trying as a urologist to explain that the anatomy it's very, very simplified, and I think having the physical therapists teach them what exercises will manipulate what parts of their body is much more effective than just like showing them a picture. And so again, we do work hand in hand depending on each individual because it is so patient specific. And I wish we could have a protocol and hopefully like as, yeah. No, yeah, it's, I think, you know, it's starting. It's definitely starting. And you are always teaching us what works and what doesn't work. And I think, you know, they have great, even the things that like I'm learning about for even just like our avoiding dysfunction patients, the balancing on the balance balls.
Swiss balls.
Yeah. Teaching them like how to strengthen their leg muscles and how that actually can like help strengthen their pelvic muscles, but then also making sure that they're relaxing and understanding the muscles that end up coping that can really get tweaked if their pelvic floor is out of sync. And just because of this scar tissue, it really can throw different parts of the body off. And so they're treating the body as a whole with a specific pelvic floor issue, which I think is very helpful. But I also don't want you to come away thinking like, oh, well, let's just go to our physical therapist and we can treat our incontinence, because that's also not an expectation that we have sending our patients to you. Right. But I think it's just an additional resource that you may not know is out there.
So really the goal is to inform you and educate you and be able to have something else to bring up to your team and see if it's appropriate for your child. We always think it's good to request a consult, and we may say physical therapy or therapy in general is not indicated. We really need to work with your medical team. Or we may see your child for just a couple of sessions and say, you know what, this is not where we need to be right now. Let's go back to your medical team. And so that's kind of where we want to inform you that there's other resources. Many times, physical therapy or any therapies are not going to fix the problem. What we hope to do is help educate you, educate your child, and hopefully make it better, make it manageable, and be able to work with the team to be able to provide more insight. Obviously, if someone has had exstrophy, we're not going to put back what was taken. The idea is to help to manage what we have, and how can we improve the quality of life? How can we help to provide insight and education? Because sometimes we just are so overwhelmed, there's so much going on. What may we have, what knowledge may we have that could help you, and what can you tell us about your child that maybe will help us learn more? And so it's really a partnership. And that's the big thing, why I wanted to have that team slide, is because it's not just physical therapy on its own or occupational therapy on its own. It's a team approach, and why we find it so important to be able to have a team, because everyone has a specific thing they're looking at, and together we can really come up with a really good plan, and maybe come up with something like a protocol or maybe an algorithm that will help guide people who maybe don't have this great team that we are able to collaborate with here. And that's why we feel so lucky to be at Children's Hospital Los Angeles, because we have the ability to speak to all our team members, and each one of them are crucial to be able to be the most efficient, the most effective, and the most successful with your child. So we're really lucky that we have a part in it, because we really do feel that we have some valuable education to provide. And if it's appropriate, we will. And if it's not appropriate, we just say, you know what, right now this is not where you need to be, and in the future, you can always come talk to us. So asking for a consult is always appropriate, and then we talk to your medical team, of course. That was a great question. Any other quick concerns? I'll also be in the lobby area, so. Great, thank you so much for having me.